Hello and welcome. In this episode today, we bring to you two clinicians who have recently published a major manuscript from virus COVID-19 registry, Dr. Anna Cervantes and Dr. Venkata Chakravarti. Dr. Cervantes is a neurocritical care physician as well as researcher, and Dr. Chakravarti Venkata is a critical care intensivist as well as he does neurocritical care too. So welcome to this episode, Dr. Cervantes and Dr.
Thank you so much for having us.
Thank you.
Well, this is your first time on our channel, so for our viewers, do you mind introducing yourself? So I'll go with Dr. Cervantes first.
Wonderful. My name is Dr. Anna Cervantes. I'm at Boston University, Boston Medical Center. I am our Chief of Neurocritical Care, as well as our Division of Neuroinfectious Disease.
Fantastic. Dr. Venkata.
Hi, my name is Chakravarti Venkata. I'm a intensivist at Mercy Hospital, St. Louis, and we also have an adjunct faculty appointment at St. Louis University School of Medicine.
Fantastic. You guys are in of the talk of the town. Your manuscript is gaining a little bit attention. So I would like let me go to right to the manuscript. Tell us about what this study is about and what are the conclusions. So any of you want to take on this message, just for our viewers, probably the researchers as well as laymen. What did you guys do?
Sure. So I'll answer this question. So very early on, it became evident that neurologic complications were of concern in patients that had severe illness, as well as in patients that had mild disease. But looking at things like prevalence and risk factors were very difficult and limited really by single center studies. So having a database like the virus database, which was international and prospective, is really the right place to be trying to answer these kind of questions. And so what we did is, in terms of all the patients that had information in the virus registry, we looked at those that had outcomes. And so we had over 16,000 patients enrolled in the registry that we had hospital discharge outcomes for. And so what we wanted to look at were really severe neurologic complications. And so the four conditions that we looked at were encephalopathy, which we looked at only at admission because there were some difficulties with getting reliable data during the hospitalization. And then we also looked at stroke, seizure, and either meningitis or encephalitis, which we captured either at hospital admission or sometime during their hospitalization. And so we wanted to look at first, just answer the question, what is the prevalence of those conditions? And then we wanted to look at pre-hospital risk factors, as well as the impact on outcomes. Now, one of the limitations of the study, which has to be disclosed, is that we don't know the timing, right? So one of the big questions that still remains and can be answered, I think, in future research is the question, for instance, like if a patient has a stroke, is the patient in the ICU, for instance, because their stroke is severe, or is a patient having a stroke as a result of severe prolonged critical illness? And that couldn't necessarily be answered with this data. But we can get some hints when we divide up whether a patient, for instance, had a stroke at the time of admission or a stroke during their hospitalization. So, with that in mind, we also looked at outcomes, both the WHO COVID severity scale, as well as things like mortality, both at ICU, hospital discharge, and at 30 days. And then finally, we also looked at utilization of ICU resources. So things like ECMO or renal replacement therapy. And so kind of just to jump in terms of what we saw as our results. So almost 13% of patients had one of these severe neurologic manifestations. This was largely driven by the fact that about 10% of patients had encephalopathy at admission. The other severe neurologic complications, I think, got a lot of attention early on in the pandemic. But fortunately, we saw that that these complications were rather rare. So 2% of patients had a stroke, 1.5% had seizure, and less than 1% had meningitis or encephalitis. One of the more interesting points, in my opinion, is that of stroke, for instance, about half of the patients with stroke actually had that diagnosis present at admission. So it does give us kind of a hint that not all strokes that are occurring in COVID are occurring just as a result of prolonged ICU stays with multisystem organ failure. We also found kind of the bottom line is across the board, if you have one of these severe neurologic complications, the likelihood that you're going to need an ICU intervention is higher, and the mortality and basically the severity of illness is higher in these patients.
Such an important result. Dr. Venkata, do you want to add to that?
Because of the sheer number of patients in the registry, I think this has, the signal is much more important is what I feel. And it's also the global database as well as prospective nature of the study makes it one of the unique aspects for the study. And as I said, encephalopathy has been shown in other studies also to have a poor outcome, clinical outcome. And this study has confirmed the same findings that encephalopathy across the board is bad. And we have captured the encephalopathy at the time of admission. And as Dr. Cervantes said, about 10% of patients have encephalopathy in this huge population.
Such an important finding, 13%. And as what I'm hearing from you is that it's not just because they were staying longer and having some of those things, but they were presenting with these symptoms. So thank you for shedding the light on such an important topic. One question come in my mind is how you guys located into different institutions, how you guys came about to work together. So tell us the story behind or process behind it, like how two different specialties or related specialty, but two different physically located systems. So what is the process? How do you guys decide to work together?
I think in the initial days of virus registry, me and Dr. Cervantes, we simultaneously submitted a similar proposal to look at the neurological outcomes in this population, because there was a lot of interest of multi-system nature of COVID-19, especially in some case reports of patients, younger patients without vascular risk factors coming into hospital. So we submitted this proposal simultaneously without knowing each other. And then with the help of SCCM discovery group, we got together and then we merged our proposals and had some guidance from senior authors from SCCM and Mayo Clinic. And we work with the help of Mayo Clinic statistician, and this has come to fruition. And there's a lot more work happening in between because of the number of data points and the patients. The statistician's help was very crucial to crunch these data numbers.
You both touch base a little bit on the implication of these results. So if you can shed a little bit more light, maybe just high level, where your study is compared now to the other published literature since you have published or since you started writing it up, any contrasting or similar findings compared to your studies?
Sure. So I think, as Dr. Venkata mentioned, at the beginning of the pandemic, there was a lot of, I think, buzz about concerns for cerebrovascular disease, for instance, in those that didn't have risk factors. And so, having a study of this size certainly is helpful at us truly understanding what the prevalence is. In terms of our results, we found similar results and really have confirmed a lot of things that have been seen in smaller studies. As Dr. Venkata mentioned, encephalopathy, at the beginning of an ICU stay, or really any time during an ICU stay for any condition, is typically associated with worse outcomes. So that part isn't as surprising in COVID. One of the things that may be different with COVID is that these patients are often presenting with encephalopathy. So it's not the result of kind of a long stay in hospital delirium. We also found that patients that ended up with a stroke, for instance, oftentimes had pre-existing cardiovascular risk factors. So that was one thing I think that was important that we found in our study here. And the patients tended to be a little bit older in our study compared to those that didn't have any neurologic complications. So those were, I think, some interesting findings.
Knowing both of you and getting a chance to interact with you on a regular basis, that you are not going to stop here. So next question is, what is next? You published one of the landmark papers. The data has grown since then. So what is next in the store?
I think we talked earlier about the fact of having about more than 70, I think, I don't remember exactly the number of patients, but there is a significant number of patients with meningoencephalitis in this registry. We talked about probably looking at more granular data about this specific population, and then having some more granularity with respect to stroke and other things like risk factors. Those are the ones that we thought about, and Dr. Cervantes can add any more.
Sure. So just to elaborate a little about the encephalitis interest, as far as I know, the largest study of encephalitis thus far is the NCOVID study. And I believe they had about 50 patients. And so while I think our study is helpful at saying, look, meningitis, encephalitis, these are really rare complications of COVID, and we probably shouldn't worry about them, there might be something special to learn about how COVID has neurologic impact by looking at these patients in particular. And so we have an opportunity with these 73 patients to potentially look at them a little bit more in detail to try to learn more about the pathophysiology of the neurologic complications of COVID. Kind of a second point that I'm very interested in, and I'm not sure if we can use the virus database, but it's certainly a place that I think that we're going to be looking next, as the really the impact of virus substrain, subtype, I think is probably a better way of putting that. So one of the beauties of the virus study is that it was done, or this neurologic sub-study of the virus study, is that we reported on patients within the first year of the pandemic. And so for the most part, that means the patients have had no pre-existing immunity to COVID because they likely haven't had COVID before, and they're unlikely to be vaccinated. When we're looking at studies of all patients, from the beginning of the pandemic until now, you're going to get a whole heterogeneous group of patients that may have some degree of immunity from prior infection or because of vaccination. And so one thing I'm interested in particular is looking at, is there a difference in neurologic manifestations for patients that are hospitalized with the original or alpha type variant, versus Delta or versus Omicron, because there may be some important differences that we learn about there.
I love it. I think these are great ideas, and especially a virus registry being one of the first registries which has all three major variants listed there, even share with the data of patients coming in. You can actually divide the cohort in those areas as well, and especially having 73 numbers compared to the largest one, which was 50, it gives a lot of power in that regard to understand about these important concepts. So, that is great ideas. I hope you pursue those, and then we get to see in future quality publications from you as well. I have two more questions, and my question is the collaboration. It's hard. It's pandemic time. You guys, many of the team members have never worked together. They might not even know them. The field is such large, and then coming together, working on projects like that, and so on and so forth. So what has been your experience? I understand that you had some hiccups in the beginning. There's no names here, but what has been your experience, and then what are the good things you want to highlight that something come out from this collaboration?
So I want to jump in and take that one first. I have to say, this was the first experience that I've had working in a multi-center study. And just to be honest out there for anyone who's early in their career as well, it was a bit intimidating to be submitting a proposal, and then even more intimidating to find out that someone's submitted something that looks almost identical and you're going to be paired together to work together. And so I have to say, it's been one of the best experiences of my life. And I'm not just saying this because I'm on camera. I really feel that I lucked out getting to work with Dr. Venkata, because from the beginning, it was always 100% a process of collaboration on utilizing and leveraging each other's talents. I do thank the pandemic for introducing us to Zoom, and I unintentionally am probably an advertisement for them, because I don't know before the pandemic how it would have been to work so seamlessly with someone who is in a different time zone, in a different state, who's also an intensivist seeing patients in the midst of the pandemic. So the experience that I've had with SCCM and with the virus registry has been uniformly positive. It's been a lot of hard work. And certainly I've learned a lot about the challenges of working with people in different sites, in different time zones, people from different backgrounds, but this has actually helped open up, I think, my own interest in continuing to work on multi-center collaboration. So it's been a wonderful experience for me.
Dr. Venkata. Thank you for those kind words, Dr. Cervantes. I've been in a community setting hospital practice, although we have trainees. Research is more of my hobby than it doesn't pay me, but I enjoy doing the research, and as Dr. Cervantes said, working with Mayo Clinic, Boston University, and the researchers from these places, it gave me something to look forward to in the midst of pandemic when we're seeing a lot of patients, and having some sort of a scholarly activity and using that part of brain was very it's refreshing for me at the time, especially when we're seeing a very sick patients day in and day out. The second thing was that to collaborate with people from India for statistics versus Mayo Clinic, and going through that process of learning the statistics and figuring it out was a big thing for me to learn in the whole process. And this collaboration has, I strongly believe this endeavor has fostered a Mercy research with the other institutes like Mayo Clinic as well as Boston, go through the whole red cap and then all the process of the IRB and other things like that.
Fantastic. So what was your personal USP for both of you guys? Not USP, but what was the secret sauce, the communication between between two of you during the early project submission, initial collaboration, then going through the analysis and redoing the analysis and so on and so forth? What has worked out? What, if you can highlight 1 or 2 points of interpersonal communication between two of you as a PIs, co-PIs, if you don't mind?
Yeah, I mean, I can say this, that realizing the strengths of other person is very important, is what I felt. She has the opportunity to have more experience with the existing literature by the time we started collaborating in the project. And so I leveraged that experience from her. And then I had the experience of working with Mayo Clinic, with other Red Cap projects and other Mayo-led multi-center trials. So I was able to communicate, or at least use my experience and to connect with Mayo guys and having the experience of Red Cap and then knowing the granularity of data. That was my experience, but leveraging her experience of writing papers and having the background experience of neurological illness of COVID. Those two things are, I think, they gelled well, I believe.
Dr. Cervantes.
Absolutely. Again, I want to reiterate, I really do feel very lucky because my partner, Dr. Venkata, is brilliant. He's very humble, very unassuming, and very patient. And so, I don't know what to say in terms of secret sauce. I think when you're working with people who are just truly good people, it's easy to work with them. It was also really fun because if all of us can, think back to the beginning days of the pandemic, I'm in Massachusetts, in a, big city, and we kind of got hit at a different time and had a kind of a different patient population, in our first wave. And then to see, kind of what Dr. Venkata is going through in a community hospital in the Midwest, his experience was a little bit different. We have different percentages of patients that were vaccinated. It was really just a truly unique experience, and one where I felt like I'm constantly learning, from my partner in this. And I think it was great that he's not a neurointensivist as the primary, training. He's a pulmonary intensivist, and myself being a neurologist and intensivist. We brought different perspectives, which I both think were beneficial for this paper.
Absolutely. So pleasing to hear that as well, and that it worked out really well for you. So as a summary, what is your take-home message? So one take-home message from the study for the layman, lay public, or anybody who's watching it today, and one take-home message for young investigators like yours who has not done collaboration and don't know. So any of you can take, or each of you can provide yours. It's up to you. Maybe Dr. Cervantes, I'll go to you to see if what is a take-home message from the study for our viewers.
Sure. So certainly in conclusion, kind of the bottom line of our virus, COVID study, the neurologic manifestations of COVID, encephalopathy is, fairly common. If you can consider 10% common at admission, while things like stroke, seizure, and meningitis and encephalitis are very rare. However, irrespective of which severe neurologic manifestation you have, all of them are associated with increased ICU utilization and poorer outcomes across the board. So I think that's kind of the summary, from our paper. In terms of, what I can say as the bottom line from the experience and advice for kind of junior investigators is just do it. It's been an incredible opportunity. I've learned so much. and you're not alone. So you have your idea, you put it out there, but there are certainly senior investigators at SCCM that will kind of help get you through it. And as long as you're willing to kind of go into it with an open mind about all that you can learn, I think other people will likely have a similarly fantastic experience.
Dr. Venkata.
Yeah, I echo the comments about trial findings. For the second part, I'll say the same thing coming from a non-university background. It's always daunting for any investigators to submit a proposals for a large studies and things like that. But I think as Dr. Cervantes said, you just have to take that step, and then if you have a good idea and then you have that enthusiasm or interest, just submit it. And SCCM has been very helpful with that, with giving us the resources that we need, whether we're in the university setting or whether in a community medicine practice. So those I think that's what I would say is to start and see and use the resources and help from SCCM Discovery.
Fantastic. Well, thank you so much to both of you. Those who don't know much about the registry, the link is going to be in comment section, or you can just Google it, SCCM Discovery Virus COVID-19 Registry. Please watch, like, and subscribe, as well as send a comment section. We will bring it to our these two principal investigators to see if the ideas you have they should work on, or any future studies ideas as well. I would like to thank both of you, Dr. Cervantes and Dr. Venkata, for being here today, doing such an important study, publishing it. It's a lot of pain, lot of hard work, and especially with data analysis and other things as well. But I'm glad that you stick together. I'm glad that you came together. It will not be possible to do such study if people of your caliber don't come together and then take it to the finish line. Thank you so much once again for being here with us.
Thank you.
Thank you for giving the opportunity.